It would be better to have a really superb ultrasound ahead of time to know what yours are like. And it would be better, in some hands, it's starting to happen now, MRV with the Heike protocol, which includes flow patterns that occur, is starting to be a really good three-dimensional way to see what your veins are like. And of course, those can tell you the azygos vein. So it's 6 of one, half a dozen the other. It costs slightly less if you don't do those tests. Okay? So if you don't have success there, fair enough. Consider another spot. And if you've got primary progressive, it's maybe not the best choice. That's my suggestion, because I think the azygos is really, really important in primary progressive MS. And Poland's quit using them, and they used lots of stents. India has backed off a lot on the jugular vein stents. Stents are indicated, especially in the azygos, sometimes in the hemiazygos. I don't think they're any longer indicated in the jugular vein unless we develop a whole new concept about them. Because when you sit up, you get almost no flow in your jugular vein. So, I know folks have them. I'm not criticizing anybody that has them. We didn't know. But I think we know more now.
One question here, and then over there, and then this gentleman. Okay, so.
Over here.
Hi. Well, assuming that MS is primarily a vascular problem, what happened with the patients that they can't not be, when they go to have the procedure, what happened when they find out that the veins are not flossed or anything like that?
Well, that's right. Now, I talked about the major study of 1,000 patients in Poland, and I have a friend that went to Poland, and she was told she didn't have any blockages to treat. All right? She was told she was in that 3%. I have since taken her films and her ultrasound data and showed it to Michael Arata, who I regard extremely highly, and he still feels there is flow patterns. My personal belief, and I think this is very close to Michael Arata's, is that if we have CCS, if we have MS, we should treat those jugular valves for sure, and in many cases also treat the azygos vein valve or something else in the azygos. Because remember, the flow is equal to the 4th power of the radius. We talk about obstruction only if it's more than 50%. That's not a big enough zone to look at. If it's 20% reduced, so still 80%, it could still have an impact. And that's why I think we have to treat proactively, and that's the piece I think we've learned, and that's why it's useful to be at a place where they'll give you some painkiller while you're having it done, which I did, and that's why it'll feel like you've been kicked in the neck. And if it doesn't feel like you've been kicked in the neck, you're 1 or 2% to have veins that large used. So I think that's where it is. I think those are undertreated people because people haven't been well enough experienced in what to do.
So can you comment on the Seattle clinic?
Where are we? Okay, thank you, sir. Well, as I said, I met Dr. McGuckin, and I met him when I was down there in mid-February. I try to get to these up-to-date meetings, and I'm going down to the one in mid-May in San Diego. Dr. Hubbard and Dr. Dake are primary speakers at that one, from Stanford and from San Diego. I would suggest, if you've got relapsing remitting MS, and fairly mild or modest secondary progressive, then you can go there. If it's your only opportunity to go, and you've got primary progressive, I'm not sure I would go there. I think he's in good hands, but I think he's in his first 100 of treating MS patients.
The secondary progressive or primary progressive, you would not go to Seattle?
Primary progressive, I would probably not go, because that's almost always azygos involvement.
You said it quite quickly. I don't think you talked about hydrocephalus.
Yes. Well, it's a good question, and it's not an easy one to talk about. We had these fluid dynamics experts talking at me. In fact, one guy talked a whole hour in practice for giving his lecture the next day. But a brilliant guy from Britain, and he's dedicated as hell because his wife has MS. Anyway, if you look at what happens to create cerebral spinal fluid flow, the blood goes into the brain, it goes into the veins, and a portion of it leaks out into the cerebral spinal fluid. And then that needs to get re-picked up again by the veins. And if either set of those veins are partially blocked and of higher pressures than normal, then the pressure builds up inside the cerebral spinal fluid. And the normal waves that happen within cerebral spinal fluid, which all the craniosacral people will tell you, are disturbed. You can renormalize them. But that is what causes the secondary injury. You may get more than enough CSF corrected. It's hard to tell people this. It's hard for people to accept the change. I've got a good friend, lives here in the island. She's maybe 5 years older than me. Her husband's an extremely close friend of mine. And they're about to shunt her hydrocephalus. She has white matter lesions. She has leukoariosis, all right? And they're going to shunt and drain the cerebral spinal fluid when I think they should be treating the vein issue instead. Now, shunts are frustrating, and they're a problem, but it's a flow into and out of, which is mostly controlled by the veins, and if the veins are under too high a pressure, it doesn't work right.
So if someone was born hydrocephalic,
Then that's the extreme. Then they shunt those, and half your times in pediatric anesthesia, trust me, are redoing shunts, because they keep blocking up. So that's the extreme, but this is a modest degree.
I have a question. I'm just wondering what your opinion is about both chelation as well as incline bed therapy.
My bed is inclined for about 6 weeks, and my wife also breathes better. Any snoring has disappeared, and I think I sleep better. It's going to be a challenge now because we're moving away from flannel sheets and you slide down a bit. So I believe in incline bed therapy. I call it a poor man's CCSVI treatment, okay? Because part of the issue is at bedtime. Now you could learn to sleep standing up or sitting up, and some of us adapt there too. And I'm sorry, the other was chelation?
Chelation.
Well, I have to be really honest. I had 10 go-arounds of chelation in '97, my touch came back. My touch disappeared when I went back to anesthesia, and it hasn't come back since. I've had a couple of assessments for chelation. I wanted them done, and I had them done before I went for my treatment. I still have hugely high mercury and lead. So my dad, as a farm kid, saying get the lead out was very appropriate.